Welcome to the Medicine and Science podcast from the BMJ. I'm Cameron Abbasi, Editor-in-Chief. In this episode of the podcast, we're taking a deep dive into AI in the consultation room.
I think what's more interesting and really not spoken about much is what you might call shadow AI use, unofficial AI use.
We look at new research on an ineffective surgical intervention.
Of course, a very bioplausible solution for that is to make room for the tendons or to remove some of the bone.
We finish with the BMJ's Christmas appeal. This year, it's MSF.
So one of the biggest struggles we have is resources. It's never enough. And then you have to get creative sometimes to manage these patients.
Firstly, generative AI in the clinic. The BMJ has published a new collection, Generative AI and the Clinical Encounter. In it, the authors use a relatively new term called triadic care. To explain what that is, I'm joined by David Navarro, a research fellow in generative AI at the Australian Institute of Health Innovation. David, thank you for joining us. I know you're on the other side of the world. It's a very different time of day there. Tell us what triadic care is, David.
So, very simply put, triadic care is the form of care that it's appearing, the care itself, the diagnosis, the management, and the support of patients is not only coming from these doctors in one side, the patients in another. That's the usual pair that we had in medicine for very long, and now with a third element informed at all levels and all processes by AI.
Okay, thank you. Interesting that you say there are those three kind of legs to the stool of triadic care. One is patients, one is clinicians, one is AI. I would, as the editor of the BMJ, say to you that we did have three legs of the stool already, and one of them was evidence. I guess evidence here is kind of mingled in with AI, is it?
Yes, I think evidence is definitely, what AI can provide. I think also what it changes is how it is provided. It's not only provided as facts. It's provided as a conversation, as an engaging conversation, and it can even provide some form of support. Even I wouldn't go all the way to say that it's empathic or at any point as a human, but a lot of people are finding also that level of engagement with AIs and with this dialogue very, very entertaining or very helpful at some point.
Yeah. I mean, just to be clear on that, I mean, there are some concerns that empathy can also be misplaced. But let's come back to those issues in a minute. Let's hear from some more of our authors about how this change that you're describing in the clinical encounter will work out. Earlier this week, Rachel Hinton, our analysis editor, spoke with Charlotte Blees, who is a researcher, and Marcus Lewis, a GP. Let's hear that conversation now.
In a practical sense, how are you seeing AI coming into the consultation room, into clinical practice?
I think one of the best titled pieces that the BMJ's published on this subject was "We don't need AI to replace clinicians, just get our computers to work first." And I think that summarizes the state of officially sanctioned AI used by doctors on a day-to-day basis. Slow rollout of AI voice transcription softwares, otherwise known as AI scribes in primary care. I think what's more interesting and really not spoken about much is what you might call shadow AI use, unofficial AI use, which will be clinicians using commercial tools, things like ChatGPT, Claude, Gemini.
So I've been leading these surveys on the use of generative AI tools. So we did this first survey in 2024. It was in January, and it was a stratified sample of 1,000 UK GPs. And this survey found 20% were using these tools for any clinical task. Nearly 3 in 10 said documentation, but about a quarter said for differential diagnosis and for suggesting treatment options. We redid it this year and it went up to 25%. And just as Marcus has said, this time was 35% said for documentation. 27% actually said for differential diagnoses, and around a quarter for referrals and treatment options. And that was, just to sort of reiterate, those were UK GPs. But what was fascinating was 95% said they had no training.
What are you seeing in the patient community when it comes to the use of these tools?
My group did a scoping review, and we found like 75% of all the surveys that look at stakeholders' experiences are among clinicians. So we do have very few patient surveys, but what we've got are pretty interesting in that people do seem to be using these tools to better understand medications, but also they're using them as a first opinion service and sometimes as a second opinion service.
But in the consultation room itself, patients will come in saying that they've done some research. And although they might not necessarily say, I've used AI, the stories and the information they arrive with are noticeably more fluent and structured than maybe from a standard web search, and they have a deeper level of understanding. I don't think it necessarily challenges the doctor-patient dynamic, because we're used to patients arriving in the consultation room with ideas about what might be wrong with them and influenced by conversations they had with friends or relatives or other healthcare professionals or searching the web. So AI is a different way of them coming armed with information.
They are becoming increasingly open to the use of AI, including with their doctors using AI. But what they don't necessarily want, and in significant percentages, do not want diagnostic and clinical decisions to be completely outsourced to AI. They want their doctor to have the final judgment and to be in the loop. So I suppose when it comes to trust, what we're seeing is increasing openness to triadic care in that sense, a place for AI in the consultation, but with the trained human professional as the overseer.
I mean, Marcus, based on what Charlotte's saying, what are some of these, potential risks that are coming out with these increasing use, whether it's declared or not within your practice?
How long have you got? Well, I think if we're accepting that there's a third voice in the consultation, and this voice is immediate, gives very quick answers, the answers are very fluent, they seem wise, confident, and they certainly seem plausible because of course AIs are trained to give answers that humans approve of. It's part of the way that they're trained, but it's a voice which is not good at saying that it doesn't know. It's not a voice that's good at recommending nothing, dealing with uncertainty. It's certainly a voice that can make mistakes, whether it's AI hallucinations or things that are more subtle, omitting important details or overemphasizing important details. AI is confidently making recommendations which might be accurate, but maybe not considering the possibility of doing nothing or watchful waiting, which is, of course, a cornerstone of medical practice. When I do speak about AI use, when I'm talking to and doing teaching for colleagues on this subject, a very basic rule of thumb is, apart from very low stakes usage, only use a large language model if you're willing to read the answer and if you've got the expertise to know if there might be errors in the answer.
I obviously completely agree with the points Marcus has made, but the thing I think we should do is also benchmark as to why people are turning to these tools as well, and all of the things that we can see that can go wrong with AI. AI can be people pleasing. It can have great conviction in its responses, in inverted commas. It can make mistakes and it can be biased. all of those things can happen in care as we know it as well. And this is where, I suppose, thinking more about triadic care, how do we get the best use of these tools where we can interrogate the responses? Doctors can do it with the patient together. So it's a case of savviness, I think, with these tools. And that's where we need to be offering greater guidance, not only to our health education for medical students and other health professionals, but patient guidance as well.
Yeah, absolutely. There's also research showing AI could potentially start de-skilling professionals. What do you sort of say to this and see this in your experience related to, the lack of potential training and preparedness for its use?
But the question of de-skilling, I think, is really interesting. And I suppose just to play devil's advocate here, is it better not to have more intimate knowledge of a patient in some circumstances or not? In some circumstances, it may be that the more you understand and you've read through and you've written the notes, you intimately understand what's going on with the patient. But in other cases, it's possible that not knowing as much might be a good thing because it prevents some kind of unwanted stereotyping in relation to their symptoms or their condition or whatever.
Okay, David, I think it was quite interesting hearing that. Clearly, there are some big issues around transparency, which, clearly, I'm sure we'd agree there isn't enough transparency, right from which clinician is using AI in which circumstances to help them with, I think, as was described, cognitive tasks of diagnosis and working out a therapeutic plan, but also in terms of how an AI or Gen AI model came up with that particular recommendation or that particular piece of advice. There's a whole range of things where transparency is required. But also, I think what was clear is that trust is central to this. And I think my concern is that there's a high degree of misplaced trust in the information that's being provided. But I just want to, before you answer that, I'd just like to pick up on three particular aspects that were discussed. Number one, about patients. Charlotte mentioned that there wasn't that much research into patients. And one of my concerns around AI is that in our rush to embrace it in the clinical encounter, the patient voice is being forgotten. So that's number one. Number two, I think there is a bit of a concern when you look at the evidence around how useful generative AI in supporting diagnosis and treatment. I think it's very unclear how much benefit we can get in those areas. Certainly, you can see the benefit in back office tasks. There needs to be fact checking and human intervention in those tasks as well. But I'd say the evidence that I've seen is much less clear around diagnosis and treatment. And finally, I was quite amused that Marcus used that quote from the BMJ, which I use a lot as well, which is a GP saying, "Don't talk to me about AI, just get my computer to work." But can you just address those bigger issues around transparency and trust for us?
Sure. I think both Marcus and Charlotte make very good points, and I definitely agree that transparency is a big issue, and that's a big part of what we trying to express and convey with triadic care is that these relations, these AI assisted diagnosis and AI second opinions, we need to bring it to light, because I think on one side, on the doctor's side, I think there could be this issue that if you have consulted something with generative AI, it can be seen that you are not using the tool that you should be using, or there can be issues around trust with the patient. Patients can be and also feel, as it has happened a lot before, that their opinions or their research are being, not considered or just perceived as you have used Dr. Google and now you have used ChatGPT. I think we we have these issues to address. In terms of trust, also, I think it's very important that trust is something that you need to build between doctors, patients, and in general, AI can play a role in both ways. Can play a role decreasing trust if all of a sudden doctors' diagnoses might come from an AI and they don't tell me what they do. And there can be this view that now the diagnosis is even less clear where it's coming from. But we also see that when doctors and patients, they have a trustful relation, a relation they have been building, use of AI or open declaration of the use of these tools, the use of decision support tools, AI diagnosis, AI scribes, doesn't really decrease the trust. I think it's a balance to strive. We need to build the trust, and AI will be a part of that trust that we need to build. So.
Okay. The bit I guess I'm concerned about is that from the paper, your paper, one of the stats, or it could have been the editorial that I came away with, was that the public trusts a recommendation from generative AI as much as it trusts a recommendation from a clinician. That's pretty worrying.
Yes, I think that's part of the issue we have with current generative AI systems and chatbots, is the way they express their answers, express generally an overconfidence, and doesn't really tell you what degree of uncertainty in those answers are, without the nuance and putting that explanation of disease or clinical reasoning into the uncertainty, into the nuance of medical practice, there can be a lot of issues.
I mean, I guess that's the point of your triadic stool analogy, which is that you've got patients, you've got clinicians and AI all working together to make a decision or come up with a shared decision-making process. Finally, on a related point, do you think we're overhyping the use of generative AI in the clinical encounter?
Well, I think with AI and with all that is happening in industry, Silicon Valley, stock markets, etc., there is certainly a degree of hype. I think that's something that it comes with most of technologies or many technologies. However, abstracting ourselves from valuations or the last declaration of one of the CEOs of these companies, I think the transformative potential of the technology, besides all that aspect, is truly great. I think we are just starting to grasp what these AIs, these advanced forms of neural networks can really do, and I think that's not hype. That's something that will happen. It might not happen next month. We won't solve all diseases and cure all cancers, as some of the CEOs are saying, with this form of AI. But I think they are transformative on its own. We need to explore that. We need to explore that aspect, and we need to shape it in a way by doing the proper research.
David, thank you very much. Let's see where this all leads us. Appreciate you joining us from Australia.
Thank you.
And that collection, Generative AI and the Clinical Encounter, is free to access on bmj.com. Next, arthroscopic subacromial decompression to reduce shoulder impingement. Surgery for this is still widespread, despite us publishing compelling trial data showing it was ineffective. Those trialists have now published a 10-year follow-up of that paper. They join us now to talk about why they kept the study going and why their first paper hasn't changed practice. Navjot Lada, our UK research editor, reports.
I'm Teppo Järvinen from the University of Helsinki, and I was trained as an orthopaedic surgeon or a bone blacksmith, but at the moment I'm mostly doing just research and running our residency program.
Give us a kind of high-level summary of what you did and what you found.
So the patients were very common patient group, patients complaining of pain when elevating the arm or something that was at least formerly considered impingement of the rotator cuff tendons and the overlying bursa. The diagnosis was created, was it 70 or even 100 years ago? Some at least plus 50 years ago, someone came up with the idea that this is caused by impingement of the tendons. And of course, a very bioplausible solution for that is to make room for the tendons or to remove some of the bone. So we wanted to test whether this very old theory works in practice. So we recruited about 200 patients, randomized them into 3 groups. One was the standard arthroscopic subacromial decompression. The other group was placebo surgery, which was diagnostic arthroscopy. So the patients basically underwent exactly the same procedure, except we didn't remove any bone. And then we also had a third group, a group that was randomized to get physical therapy and then some home exercises.
So what did you find?
What we found was that the surgery was very effective in the sense that very soon after undergoing surgery, all of the patients reported huge improvements in pain scores and in the functional scores. The problem, at least from the perspective of being a surgeon, was that the improvement was no better in the active or in the ASD group than in the placebo group. So it was basically all placebo. And as we had also had the third group, very soon all 3 groups reported very highly similar, comparable recovery, comparable outcomes. They were not identical, but very similar at 2 years. And then the picture just kept getting more certain. At 5 years, there were no differences. And at 10 years, all the 3 groups, no difference, especially between the placebo surgery and the active surgery groups.
Let's talk. I want to make sure we talk about the follow-up period and what was involved in doing a 10-year follow-up of a trial. I mean, that seems, and I think it's 87% of participants are included in this 10-year analysis, which is really remarkable. Tell us a little bit about, what went into getting that follow-up, but then also what are some of the challenges and things you need to think about when interpreting those follow-up results?
Yeah, I mean, 10 years, I don't even want to be shown pictures of what I looked like when we started the trial. Launched the trial in 2005, and now we published the trial just before it turns 2026. So what went into that? I mean, it's just hard labor to keep people involved. It means treating them well whenever they have complaints, whenever they have concerns. One of the benefits why Finland seems to be kind of one of the better places to do placebo surgery kind of research is that people still trust the healthcare system. They are nice people, so they trust us and they think that we are not using them as guinea pigs. Rather, we are really trying to help, and we are trying to find an answer to a question that it seems to be relevant. And a lot of our patients actually told us that they understand that this may not benefit them, but they want this to contribute to greater good, which is to me like the essence of doing research.
Mm-hmm. So the earlier trial publications that you've had at 2 and 5 years have been influential in informing recommendations not to do arthroscopic shoulder decompression for this indication. This 10-year follow-up would appear to cement that as well. And yet I think it's still happening, which I think is why this 10-year follow-up is so interesting. And that was something we talked about when we were considering the paper, is that okay, the message is similar, but it's still relevant because people are still doing it. What's been your experience of following these patients up and I guess communicating these results with the wider world? What do you think is going on? Why is it still happening when there is this kind of clear message?
Yeah, I mean, this could end up being a very, very long story, but just to try to make it short, you told that this was our previous publication that was published, the 2-year follow-up was published in 2018 in the BMJ. The year after, the BMJ Rapid Recommendation Group published a very, I don't know whether it was influential, but at least a very clear guideline recommending against this surgery virtually in any and all imaginable patients with this kind of complaint. But as it seems to happen in every medical discipline, the specialists know better. And I mean, this isn't unique to orthopedic surgery. This is very common across pretty much the entire range of medical disciplines, that the specialists always know better. What they do not know better, and I can say for certainty that they do not know better the principles of evidence-based medicine or how research evidence should be assessed, but they just know better. And this is what kind of happened. I mean, a very influential, a very credible guideline organization sums up all the evidence using the best available techniques and methods, and ends up concluding that this surgery is futile. And then we have an avalanche of papers written in all kinds of orthopedic journals and letters submitted to even the BMJ criticizing the paper and the methods and whatever. So I mean, I guess this is the problem with medicine, that people tend to believe what they want to believe, and but I also want to kind of emphasize that I'm not sure whether I should be proud of the Finnish surgeons, because we were probably the ones doing the most of these surgeries. So our incidences were the highest before the FIMPACT trial was published, and we actually had at least one prior randomized trial comparing the surgery to non-operative treatment, but our rates have gone down by 90%. But I guess we are exception to the rule, because as you kind of pointed out, I think there are still like nearly 30,000 of these procedures performed each year in the UK, even though a very similar study to ours, a placebo surgery control trial, came out from the UK in 2018, so the same year as our FIMPACT trial. So evidence doesn't seem to move surgeons.
Yeah, I mean, and as you say, it is a story we see repeated through many disciplines of medicine, particularly where a treatment is established before it's been studied in a trial, and it has this kind of plausible mechanism. So you think, well, of course it should work. It does work. So Teppo, what do you think is needed for things to change?
If you read why the BMJ Rapid Recommendation, and my disclaimer is Gordon Guyatt is my huge mentor and hero. But anyway, how the guideline panels are assembled, having methodologists and content experts and patients, and having balanced panels rather than all these specialty societies having panels with experts and with loads of not just financial but other conflicts of interest. So I think that would be, I would really appreciate the difficulty of saying that medical reversals will never occur unless we as a medical discipline, as a community, accept the fact that people with any kind of intellectual or financial conflicts will not be allowed to make decisions on the viability of the treatments that they are giving.
And that article, Arthroscopic Subacromial Decompression versus Placebo Surgery for Subacromial Pain Syndrome, is available on bmj.com. Every year at this time, the BMJ launches its Christmas appeal, and this year we've chosen Médecins Sans Frontières as our charity. It's not the first time we've raised money for MSF, but given the ongoing conflict in Gaza, Sudan and Yemen, we felt it was right to help them again.
I'm Rebecca Coombs, Head of Journalism at the BMJ. We've been reporting all year on the incredible work that MSF are doing in conflict situations around the world. And while that work is essential, we also wanted to highlight other places they are active. I had a chance to speak to one of MSF doctors working in Nigeria in a cholera treatment centre. MSF work closely with the government in Nigeria, providing services within a hospital, creating specialised units to deal with the cholera outbreak. That's a huge logistical challenge when basics like clean water and power are lacking. They also support volunteer doctors and nurses who help run these wards.
My name is Dr. Shafatu Yusuf Abdulkadir. I think I've been practicing medicine for over 7 years now. I'm the emergency medical activities manager. My day never really ends per se. Most times my day even starts before the sun, rises. Sometimes I can spend, you don't sleep deep because you know there's something waiting for you. So by 5, you're already preparing the day. So here during the cholera outbreak, there's a WhatsApp we create where you post the cases that came through the night. You highlight the worst cases that came through the night. So my day starts by going through that. If there's any mortality, we have to check for that mortality and, continue following up in the morning. So I read those messages and I pray to God there's no death. And then by 8 o'clock, I'm doing a walk around. So the walk around is, first, I want to see what is the situation in the ward. I want to be sure that we're giving the best care and we're using the protocol properly and ensuring that the patients are getting the best. So I do those walk around. I do a multiple walk around as the day goes. So most times my day starts really early.
Could you tell me a little bit about the realities of dealing with cholera patients?
Dealing with cholera, first of all, we all know cholera usually most times occurs in a resource-limited setting. So one of the biggest struggles we have is resources. It's never enough. And then you have to get creative sometimes to manage these patients and manage the staff. Because you come to a cholera unit, it's vomiting and diarrhea consistently. You need IV fluids, you need this. We're always almost running out of, supplies. As of now, I'm speaking to you, we've run out of antibiotics. Azithromycin is finished.
Really? So very, very essential resources you're running out of.
Yeah, we're running out of azithromycin. Our ringus is going down. And before our stock arrives, we have to get creative. You have to start estimating weights and pushing for things. So a lot of the times it's me, the patient, and me, the hospital management. And it's a lot of things because this center, the CTC is located inside the center. And the center is also under-equipped.
So does the MSF team take over a ward or a series of wards then in order to provide the care? And how many patients on average are you dealing with?
Okay, so when we arrived, there was a CTC created. But on arrival, the CTC had nothing. It had no circuit, it had no organization, it had nothing. So when we came, we had to create the circuits, create the IPC protocol, create the water was a problem. Water is a problem. We don't have water. So we depend on water trucking. So we have to truck in water. We had to find a triage. We created a temporary tent where we triage and stabilize patients. On a good day, in 24 hours, we can admit over 30 patients with cholera, over 30. I have requested with the logistics to help us fabricate, cholera beds, because our cholera beds currently are not enough. So I'm really proud of my team because with the little we have, we made a lot of difference.
And can you explain to me what MSF logistics team is and what they do?
Okay, so the logistics team here provide us with almost every other thing we need: stationaries, waste disposal, dustbins. When we're running out of water, we call them to say, look, right, we are running out of water. We're running out of hand washing soaps, or we need a new tripod stand for drips. So yeah, we work everything I'm requesting. Yes. So yeah, we work closely together.
What difference do donations to MSF make in concrete terms on the ground to people like you doing the work you do?
I think for that, if I'm going to if a donor was in front of me one-on-one, I would probably tell them they are providing that as little as the money they, €1, no amount is even small, because that amount someone donates is buying ringers, is buying ORS, is buying chlorination tablets, is providing clean water. That donation is saving one life, at the same time saving a generation. That donation is giving hope. That donation is equipping the nurses. That donation is equipping the doctors. That donation is going beyond medicine. Your donation feeds somebody. You give someone a hot plate of food. They probably, and I can say from working and being from this part of the country, a hot plate of food is a luxury at this point. Water is a luxury. These are basic necessities of life, but it becomes a luxury in a place like this. And when you donate, you're lighting up a soul, you're giving hope for the future, you're making a big difference.
And if you want to donate to that Christmas appeal, we've added links in the podcast notes. That's it for this episode of the Medicine and Science Podcast. Next episode is the last one of this year, and we'll be taking you through the Christmas BMJ. But no spoilers. Until then, I'm Cameron Abbasi. Thanks for listening.